is no perfect solution, and you will clearly see that from my presentation. This is my disclosure, non-relevant to this particular topic. I'm going to start by showing my experience with one of the challenging patients, and it just highlights that none of us are immune to this problem. So this is a 52-year-old female with history of prior anterior posterior surgery. She presents with this clinical picture. She's stooped forward, has severe back pain. She's not able to ambulate, barely able to get around and take care of herself. And she has some multiple surgeries, as I mentioned, that she's also severely osteoporotic. These are her radiographs. She had prior long fusion from the upper thoracic spine to the sacrum. And these are her parameters, SVA, more than 38 centimeter with lumbar lordosis, in fact, kyphosis of 42 degrees. She's also on chronic narcotics. What's positive about this patient is that she was still working, and that really says a lot about this patient's character. These are the DEXA numbers. You can see some of the worst number, minus 4.5 T-scores, which highlight the difficulty with her achieving or maintaining any type of correction. So I took her to the operating room and did a very long revision surgery from the upper thoracic to the sacrum. I used a lot of the techniques I use, including transverse hook at the top. I thought I got good correction. I tapped myself on the shoulder and said, that looks good. Well, follow-up is the greatest spoiler of your confidence. So this patient looked like that within 3 weeks after surgery. Looks relatively okay. But then as we see her again, you're starting to see some changes here. And she started developing frank PJK above the fusion. I had to extend her up to the cervical spine, and fortunately, she held okay after that. So proximal junctional kyphosis, and I know this term is used alternatively with proximal junctional failure or proximal junctional adjacent level degeneration, etc. And I will touch base on that a little bit. So what is proximal junctional kyphosis? It's kyphosis at the upper instrumented level, or UIV, of more than 10 degrees with a sagittal cup angle from the inferior end plate of UIV to superior end plate of UIV plus 2. Incidence has been widely reported, and that just tells you we're probably not measuring exactly the same numbers or looking at the same patients. PJK, let's stress that it is not a clinical diagnosis, it's a radiographic diagnosis. So that means the patients may not necessarily have the exact same outcome or have difficulty with a PJK of certain amount or certain magnitude. So some may be asymptomatic, related to some reciprocal change, but some may be severe, like proximal junctional failure, and maybe even associated with neurologic deficit. There are mixed data on PJK and clinical outcome. Looking at this study from WashU, Kim and others, showing that patients with PJK had 12 times more likely to have, or pain that continued to have pain after surgery, more likely to have PJK. SRS pain score was higher in PJK, but no difference really in magnitude of ODI improvement, which is interesting finding in this study. Role of proximal junctional or PJA angle, and that's the way we measure PJK. So this is a retrospective study looking at 75 patient, 5-year follow-up. Magnitude of the PJA or proximal junctional angle is important. PJA continues to progress at 5 years. So it's not really the early failure. This is more of the progressive ongoing failure or what's commonly referred to as PJK. 76% of PJK cases identified in less than 3 months. And I would call those mostly PJF, really. Most changes occur 12 weeks after surgery. SRS and ODI, no different in PJK versus non-PJK. But again, are we looking at apples to apples or not? And that's important to understand. So PJF, PJK with severe symptoms and radiographic finding, and that's what I would like to define PJF as. It can be associated with neurologic deficit, and these can be pretty severe: impaired posture, implant failure, And these are typically going to require surgery. Unfortunately, the definitions are not quite standardized. Now, classification, some have attempted to do different classification for this, including Boachi and others, and dividing them into type or subtype. 1 is ligamentous, 2 is bone, 3 is implant and bone failure. Unfortunately, none of these classifications were allowed us to dictate treatment necessarily. This is, again, an example of both bony and ligamentous failure. Bob Hart within the ISSG has also come up with a classification talking about neurodeficit and giving them numeric values, and a score of more than 7 would usually dictate surgery. So risk factors, I mean, there are patient risk factor, age, osteoporosis, obesity, magnitude of preoperative deformity, sagittal imbalance, thoracic kyphosis. And osteoporosis is a big factor for PJF, not necessarily PJK or that gradual long-term change. So about technique, and I think that plays a major role, and that's what we have improved on over the past several years. Soft tissue disruption, so clearly preserving the ligament, facet, muscles. So patients who have poor muscles, and some MRI studies showing significant correlation with the muscle signal to occurrence of PJK. Using rigid construct, now we're using bigger, stronger, thicker metals and doing longer fusion. Clearly that's contributing to what you're seeing. Appropriate UIV, LIV selection is clearly goes without saying, trying to overcorrect in some of these patients. Some of the prevention technique, and again, the topic of this talk is primarily on prevention. Vertebroplasty, and I worked a lot on vertebroplasty and now have mixed feelings about it, and I'll highlight that to you. Transverse process hook or a softer landing, terminal rod contouring, this as a technique. You don't want to force or pull the spine too much at the UIV. Softer fusion, people avoided fusing the proximal segment. And some have used other less common things like the Vector. And we have tried using MIS at the proximal junction with some degree of success. So vertebroplasty, we started doing that more than 12, 15, 13 years ago. And because we're seeing a lot of bony failure, and that's really what it helped with. Cement increases the mechanical strength immediately, so it helps with patients who have osteoporosis. So it has contributed to lower rate of PJK. But in retrospect, when we look back at our study, it was really lower rate of PGF as opposed to lower rate of PJK. Some other centers have replicated our finding and showing improvement and less acute failure. So this is another study as well, retrospective 85 patient, larger number, showing again some improvement, especially radiographic improvement. Now, when we followed up our patients now up to 5 years, you can see that again, follow-up destroys our great results, really. And we started seeing more PJK occurring later on. And really, when you read our data and you look at it with closely, you realize that we're really preventing PJF and we're not preventing this gradual change over time, or what I like to call it PJK. So we're preventing acute failure, but as we follow these patients longer, it becomes less effective. And this is a patient, one of my earliest patients. You can see good alignment early on. Over time, you're starting to see some kyphosis at the junction, and it has progressed. This work was based on a biomechanics study we did, and we cemented the UIV and UIV +1 and compared it to no cement, and also compared it to UIV cement application. And the best group were those who had UIV plus as well as UIV +1. So in summary, vertebroplasty, there's really not a lot of level 1 data. I mean, it provide benefit in osteoporotic bone. And that's why, as we started using anabolics and other biologic to improve bone strength, we have seen less of those acute failure. It's likely cost effective as it's really cheap to do. And however concerned, it affects blood supply probably to the disc and may accelerate degeneration. In fact, and I've seen that myself. Cement leakage and embolization has been reported, so it can be a factor. Using an alternate fixation, I know everybody uses pedicle screws now, everywhere now. We have started using hooks at the UIV with some very degree of success. Hook fixation requires less dissection because of the trajectory, less dissection, less destruction of the bone and ligaments, etc. And we have seen it actually improving our outcome as far as PJK. This is a study that one of my former fellow has done, Dr. Hassan Zada, and looking at early results, 47 patients, we actually saw much lower risk of PJK, and we continue to use hooks at the UIV in the upper thoracic spine, not in the lower thoracic spine. And some others have shown similar results in AIS patient as well as in adult patient. This is an example, patient with ADIS, and you can see we used hooks at the top. We used, this is a long fusion, and this patient is 10 years out and continues to have good outcome with no failure. So in summary, again, no level 1 data, likely effective for upper thoracic UIV, and I stress that, upper thoracic UIV, less soft tissue disruption, smooth transition, less costly or less cost effective likely cost effective as it prevents revision surgery. Now, newer techniques you've heard about, some of the companies, I'm not going to talk about specific ones, using some tethers to facilitate smoother transition between fused and unfused segment with the tether weave between spinous processes, potential for significant benefit if reduces cost of revision surgery. And these are applied. The problem with all these techniques, they require exposure or some degree of exposure with some muscle dissection, etc., which I think by themselves have or create another problem. But if we can apply them without collateral damage to the area, maybe we can prevent it. Early study, and again, this is very early, and this was done by my current fellow, Michael Safai, actually at his home institution, not in our series or patients. And they looked at 200 patients, 100 each, and they were not randomized, but they showed that ligament augmentation showed smaller change in PGA, lower rate of revision for PGF, 4 versus 18. So looks very promising, at least early on. Percutaneous fixation, again, we've used that and others have used it. So the goal is to try to minimize dissections, try to minimize disruption of the muscles, ligaments, and soft tissue envelope, and have shown some promising results. A newer technique we've been using, or just some a modification of placement of the proximal screws. We recently published our data looking at the UIV and angling the screw away from the proximal end plate has shown some improvement and less occurrence of PJK as well. In summary, the majority of PJK occur early, and I think the most concerning one are PGF. Most cases will progress radiographically. Follow-up is clearly important. Radiographic PJK alone may have worse outcome, but pain probably worse, but SRS 22 ODI seems to be similar, at least in many of these studies. So I think the focus should probably be on PGF, because junctional failure is bigger problem. Probably bone quality is a critical factor, and that's why we're very careful now about choosing our patient, about treating them early to improve their bone density. Severe osteoporosis is clearly now a contraindication, or at least a relative contraindication. So we should treat all these patients for osteoporosis, choose appropriate anchors for the levels as well as the location of the vertebra. So we do cement augmentation in osteoporotic patient in the lower thoracic, but hooks in the upper thoracic. Well, I think I'm going to stop here. Thank you.